أخت مريم. مريم تسمعيني؟
ايوه
أيوة نبدأ.
اهلا تسمعوني؟
نعم.
ايوه اهلا تسمعوني؟ نعم. ايوه اهلا تسمعوني؟ نعم. ايوه اهلا تسمعوني؟
You can start أخت مريم. كل الجميع يسكر الميكروفونات اللي دكتور مريم دكتور حسين لين عشان ما يستوي صدى. You can start أخت مريم.
أخ سعيد، مريم عندها مشكلة، فأنا إن شاء الله ببتدي رفيعة.
أوكي.
السلام عليكم جميعا.
السلام عليكم.
أوكي، السلام عليكم جميعا.
عليكم السلام والرحمة.
مريم, you can start if your mic is working. مريم. Okay, so let's start. السلام عليكم جميعا، معكم رفيعة العفاري، مدير إدارة علاقات الدارسين. أولاً أحب أشكر الدكتور سعيد والدكتورة مريم قلداري إن لهالفرصة الجميلة إن يسووا لنا هالوركشوب، وإن شاء الله الكل يستفيد من هالوركشوب. هذه ثاني كولابوريشن مع الUAE Pharmacy، وإن شاء الله ما بيكون هذا آخر وركشوب، بتكون إن شاء الله في سلسلة من الوركشوبس الجاية إن شاء الله. أعطيكم المايك دكتورة مريم.
شكرا حبيبتي رفيعة.
اتفضل.
شكرا، أشكرك.
الله يخليك.
شكرا. السلام عليكم جميعا. طبعا I'm delighted to be with you today. I would like to brief you about EMA, Emirates Medical Association. EMA it is a non-profit public benefit organization. Consists about 43 specialized society in the health sector. One of this society is the pharmacy society. طبعا I would like to invite all of you today to join and be a member.
The voice is gone.
الصوت قطع عندك دكتورة، ما نسمعك. سعيد can you hear دكتورة مريم؟
لا ما اسمعها.
Maybe the voice is cutting from her side. She left. Maybe she has a problem with the connection. Maybe, yeah. Because I don't see her name.
Maybe we can start, Dr. Saeed Hussein. Then we can go for.
Okay, I will introduce myself. My name is Saeed Hussein. I'm a clinical pharmacist at Zayed Military Hospital. And first of all, I want to thank Maryam and Samir from Hamdan, Mohammed and Rafia, and also Dr. Maryam and Dr. Hussein. He's the one behind this session. He suggests this session. Are you hearing me?
Yes, I'm with you.
Very clear, yes.
Okay.
نسمعك. انتم ما حد يسمعني، انا ما سمعتوني.
لا والله ما سمعناك. خلاص انا انتروديوس
انت منو عفوا؟ انت منو تتكلم؟ رفيعه؟
دكتوره مريم القلداري.
دكتوره
مريم، انت كنت صارت دكتوره مريم، انا ما اشوف.
نعم
صوتك انقطع فجاه.
معقول ما اعرف والله، انا تكلمت يعني ما ادري.
anyway ما في مشكله. خلاص انا بكمل وبعدين نسوي انترودكشن للدكتور حسين بعدي.
لا دكتوره مريم كملي كلامك، معليش.
اذا تقدري تكملي اوكي، عيدي مره ثانيه.
تفضلي دكتوره تفضلي.
يعني وين انا يعني
عندي لما تكلمتي عن السوشيتي فيها 43 سوشيتي.
Yes, it is 43 society in Emirates Medical Association. Hello. الو
ايوه نسمعك
دكتورة نسمعك
زين يعني this contains more than 43 specialist society في الهيلث سيكتور ومن ضمنهم one of them pharmacy society. طبعا I would like to invite all of you today to join and will be the member in this association, Emirates Medical Association. Today the session will be about the principle of antimicrobial. طبعا the speaker Dr. Saeed Hussein. Dr. Saeed Hussein, he is clinical pharmacist at Zayed Military Hospital. He have more than 19 years experience in both inpatient and outpatient. He has graduated from Faculty of Pharmacy and obtained his master in the clinical pharmacy in Ajman University. And another master in the public administration from Mohammed bin Rashid School of Government. He holds the American boards in oncology, pharmacotherapy, intensive care board, infectious disease, and antimicrobial. He have research PhD research at the Hamdan bin Mohammed Smart University. Dr. Saeed, he's also chairperson in the scientific committee in the Pharmacy Society and president of Emirates Clinical Pharmacy Science طبعا scientific committee. Welcome, Dr. Hussein. Dr. Saeed.
Thank you very much.
أيوة أسمعك. Welcome.
أهلا وسهلا.
Welcome.
I will start. Thank you very much for this nice introduction. First of all, I want to thank Maryam and Samir from Hamdan and Rafi'a from Hamdan University, Dr. Maryam Galadari, and Dr. Hussein. He's the one who suggests this session. And I will start. So first of all, let us define antimicrobial stewardship program. So what is the antimicrobial stewardship program? In simple definition, is the rational use of is the program to guarantee the rational use of antibiotic. Another definition we can say is the use of the right antibiotic for the right for the right patient, for the right dose, for right frequency, for the right duration, for the right organism for this patient and next patient.
الصوت يروح دكتور سعيد يروح ويرجع.
الكل نفس الشيء الجميع.
No, it's very clear to me.
Clear from my side.
It's very clear. It's very clear.
دكتورة مريم سكري الميكروفون.
My side is also clear, but everyone should close the mic.
دكتورة مريم سكري المايك. So let us actually I will talk about the principles, and the principle will not change whether we have COVID or not COVID. Dr. Hussein will focus on COVID per se, but for me I will talk about the principles, and I will throw the principles in direct way. So let us talk about, because you know we have pharmacists, we have doctors, we have nurses, we have even students. So and we have some people who's already consultant ID, and we have different background. So allow me to talk about the basics, so everybody will be on the same track. So we have, in general speaking, we have gram-positive bacteria and gram-negative bacteria. And I want to focus on two main things in the structure of the cell wall. So there's 2 points I want to focus here. Number one, why the gram-positive behave differently when we staining with gram staining than gram negative. Example of gram positive is Staphylococcus aureus, and example of gram negative is E. coli. The main answer is for this is the peptidoglycan cell wall, where it is thick in gram positive. On the other hand, is very thin in gram negative. So this will allow the violet color to stay, and when we wash it, it will not be washed. So end of the day, it will be violet color, the gram positive. On the other hand, in the gram negative, when we wash it, it will be washed, and if we put another color like pink color, it will give pink color. That's why the gram staining is different, and this is very important in stewardship. You can discontinue sometime antibiotic based on the gram staining. For example, you start empirically to cover MRSA, and it came gram negative only in the gram staining. So maybe that time you can stop, for example, vancomycin, and you cannot wait for the culture for 3 days or 4 days. The second point I want to highlight is the why gram negative bacteria is hard to treat compared with gram positive. The answer is this layer, plasma membrane. There is layer from inside and layer from outside. These two layers make it difficult for antibiotic to penetrate. That's why the antibiotic here will not work easily in gram negative. But again, in gram positive also there is some difficult bacteria. A slide is gone, yeah, Samir? Samir?
Slides are back now.
Okay, so let us. This is gram positive bacteria. Most common gram positive, which is pathogenic. We have Staphylococcus, we have Streptococcus. You can see here Streptococcus pneumonia, and you can see here Staphylococcus. There is many, but I will focus on Staphylococcus aureus. There is MSSA and MRSA. MSSA is nice bacteria compared with MRSA, which is very difficult. Only limited antibiotic will work. I will another slide. I will show you which antibiotic will work on MRSA and which antibiotic will work on MSSA. But even within MRSA, there is a community acquired MRSA and community acquired and hospital acquired MSA. Usually, hospital acquired MSA more resistant and more difficult to treat compared with community acquired MRSA. In gram negative, we have many bacteria which is pathogenic, but the biggest family is Enterobacteriaceae. For example, E. coli, Escherichia coli, or Klebsiella pneumonia. Pseudomonas also is under gram negative. I will focus on one difficult bacteria, Klebsiella pneumonia. It's very common in hospital setting, hospital acquired infection. We have the normal one, which is susceptible, Klebsiella pneumonia, usually sensitive to most to high group of antibiotic like ceftriaxone, third generation, cephalosporin, tazocine, fluoroquinolone, etc., according to your antibiogram. But if this bacteria start to behave in a resistant way, it start to be ESBL Klebsiella pneumonia. Means what? It start to produce enzyme which destroys ceftriaxone. So this is in this time you need to go for antibiotic which will work on ESBL like ertapenem, ceftalazone. This is new antibiotic, tazobactam or meropenem. But if it's clear Klebsiella ESBL, we prefer ertapenem or ceftalazone, tazobactam, and we will spare maybe meropenem for Pseudomonas. Third level of resistance when it became CRE. In this time, ertapenem and meropenem will not work because it's carbamazepine resistant or KBC. It produces higher level of enzyme, even higher than ESBL, which destroy the antibiotics. So in this time, there's a new antibiotic, ceftazidime, which is third generation with avibactam, beta-lactamase inhibitor. This will work. Or there's another one, meropenem, in combination with vabrobactam. We don't have it yet in UAE. But even in CRE, there is a one type. Even this antibiotic will not work when we have CRE beta-lactamase. In this stage, we need to combine ceftazidime, avibactam, maybe with astronam. Astronam is monobactam, but together this may work. Also, there is a new antibiotic. It's called plasmocin. Here I want just to focus on a typical organism. A typical organism, because it's community-acquired pneumonia. There is a lot of antibiotic, which a lot of bacteria, which is a typical organism. It can cause community-acquired infection. Clostridium difficile is one example of anaerobe, and this is the result of misuse of antibiotic. Or if you use broad spectrum, it may lead to Clostridium difficile, where the antibiotic will kill all the bacteria, and only, for example, Clostridium will cause the diarrhea, and will at this time, in this stage, we have to review the antibiotic if it's needed or not needed, and stop it. And maybe we need to treat Clostridium difficile with the vancomycin, for example, or another antibiotic will work on Clostridium difficile. This slide is very, very important slide. It contains all antibiotics available, most of the antibiotic available in the market. I will focus on certain points. Number one, the mechanism of action. We have three main mechanisms of action: either cell wall and cell membrane, or protein, inhibit protein synthesis, or inhibit RNA and DNA and nucleic acid. And this beta-lactam group, which is in cell wall, is the most important antibiotic. We have penicillins, which is started from narrow spectrum to the extended spectrum. The only antibiotic which will work on Pseudomonas from penicillin is piperacillin. Then we have cephalosporin. We have until now 5th generation. The level, the coverage, it will start the 1st generation gram positive and little gram negative. As you go higher in the generation, more gram negative will cover and less gram positive. We have which antibiotic will cover Pseudomonas? Only one example in 3rd generation, which is ceftazidime, and one example in cefepime in 5th generation, and the two new cephalosporins, ceftalazone, tazobactam, and ceftazidime, avibactam. This all covers Pseudomonas. In case of meropenem, menobactam, and carbaminims, can somebody tell me which carbaminim will not cover Pseudomonas? Anybody can tell one of the carbaminim which will not cover Pseudomonas? Can you write it?
Ertapenem.
Yes, thank you very much. Thank you very much. We have also now another antibiotic which will work on Pseudomonas is ciprofloxacin and levofloxacin. Can somebody give me one example of fluoroquinolones which will not work on Pseudomonas? Moxifloxacin, absolutely. So not all fluoroquinolone work on Pseudomonas. Let us now shift to MRSA. So MRSA, none of beta-lactam will cover MRSA except beta-lactam. None of beta-lactam will cover MRSA except one. New one. Ceftralone. Ceftralone, no, not 4th generation. This is 5th generation or advanced generation. Ceftralone or ceftralone, this will cover MRSA. Vancomycin, as somebody, yes, exactly, ceftralone. We have also vancomycin will cover MRSA. When we go to proteins, this is tetracycline and its groups can cover MRSA, including tigacyl. Also clindamycin, but usually we will use it for community acquired. Linezolid also will cover MRSA. Daptomycin, ciptrin will cover also MRSA. This is a nice slide. It will help you to guess which antibiotic may work. For example, if you take this line with Pseudomonas, and you go down all the way, you will see it's empty. So it gives you the impression that none of this antibiotic will work on Pseudomonas. So neither penicillins, nor augmentin. So which antibiotic will work? Gentamicin will work, and tobramycin, ciprofloxacin, not moxifloxacin. You see, there is a space here. What about second and third generation cephalosporin? It will not work. Ceftazidime will work, cefabime will work, piperacillin will work, meropenem, but not ertapenem, not Tigasil. So you will know which, but again, this depends on the actual culture. But this is, you can at least guess it may work. On the other hand, if you come to gram positive, and you can see in MSSA, which is methicillin sensitive or oxacillin sensitive, we have a lot of options. Most of the antibiotic will work, but not penicillin alone, neither amoxicillin. But when you add the clavulanic, it will work on MSSA. You can see also here, cipro and ciprofloxacin, it will not work. Ceftazidime, it will not work. Meropenem, it will work, etc. But if you go to MRSA, we have very, very limited. Here we can see clindamycin, we can see vancomycin, teicoplanin, linezolid, and daptomycin. Ciptrin can work on both. Gentamicin may work, may not work. Moxifloxacin may work on MSSA, but not on MRSA. So the question is, meropenem work on MRSA? Can somebody tell me? Can meropenem work on MRSA? No. So, yes. So so sometimes we will think meropenem is the covering everything, but it's not covering MRSA, and there is another organism which is not covered. This is just an example. So when you prescribe antibiotic, you need to balance between risk versus benefit. So there is two things you need to think about it. The first one is to assure effective treatment of the patient with infection. The second one is to minimize the collateral harm. Some example of collateral harm is the C. difficile and the resistant and the side effect of the medication. For example, QT prolongation from fluoroquinolones or azithromycin. For example, drug-drug interaction, fluoroquinolone may cause hypoglycemia, etc. So you need to balance. There is no, it's not pure benefit. There is a benefit and there is harm. So you need to be wise when you prescribe antibiotic. You maybe lead to harm if it's not needed. Antibiotic usually prescribed for three main things. For prophylaxis, empirical, and definitive. Definitive, it is easy because already you have the culture, but you be wise for selection according to the site of infection. Prophylaxis, you need to have a guideline. You need to give the narrowest possible antibiotic within the right time, within 1 hour of the surgery. Most of the time, only pre-op. Some surgery can be 24 hours, like cabbage. You have to consider the allergy. You have to consider MRSA, for example. If MRSA patient is carrying MRSA, maybe you think about Vanco instead of cefazolin. The drug of choice, most of the surgery is cefazolin, and you can add to it metronidazole if you want to cover anaerobe. Some hospital, they are going to ceftriaxone third generation. This is high risk for resistant development, especially ASPL. Empirical is the most important thing when you are treating empirically. I will focus on the coming slides on the empirical treatment. So empirical treatment, what is the optimal antimicrobial? You have to select the right drug, again, for the right, with the right dose, right duration, right route. You have to think about the antibiotic if it's time dependent and or concentration dependent as a part of the dose, right dose. You need to do vancomycin and aminoglycoside monitoring, pharmacokinetic, pharmacodynamic, because to avoid toxicity and under treatment. So if you're doing that one, you will guarantee again the right the drug dose and duration. And for this patient and the next patient, which empirical antimicrobial you can start? You have to do the initial evaluation, and you use the diagnosis do clinical assessment, use diagnostic work up, then according to the case, and you need to take the best therapeutic decision, and you do patient education initially, and most importantly, after 2-3 days, you need to reevaluate what you did in the beginning and see if the patient is responding, if there is a culture, and modify the antibiotic based on the situation. So this is one of the main principles of antimicrobial stewardship, to reevaluate and do the needful, like de-escalation, for example. There is 5 things you need to think about it when you are prescribing antibiotic. If you think about it in a systematic way, it will help you to the right to take the best decision. Number 1, how is the patient's severity? Is he critically ill, or patient is stable? So timing is important. If patient have shock, you need to give it with the antibiotic within 1 hour. Route, you need to give it IV or oral. Spectrum, wide spectrum or narrow spectrum. Source of infection. You need to think about the source of infection. For example, if you are treating urinary tract infection, you will think about E. coli, to cover E. coli. And also source control is very important. For example, if you have patient with intra-abdominal infection and he have collection, you have to do something to remove that collection. Otherwise, antibiotic without source control, it is useless. Drug resistant, you need to think about recent antimicrobial use. Local if the patient used within 90 days antibiotic IV, it is one of the highest risk for developing resistance. So maybe you need to give to cover the resistant organism in this case. Also, you need to look to your data antibiogram. If your antibiogram, if you have what's antibiogram? For those people who don't know, antibiogram is a table which contain bacteria and antibiotic sensitivity for the last year. For example, if you have E. coli 100 organism last year and it was 90% sensitive, so you can give ceftriaxone empirically because you have the trust. It is sensitive 90%, but if it's only 20 or 30%, you will not take the risk and give ceftriaxone empirically. You maybe go to higher level of antibiotic, like for example ertapenem, according to your antibiogram data. Patient factors, another 5th point. If patient is allergic, patient is renal or have renal problem or liver problem, you have to adjust the dose based on this. If the patient is pregnant or lactating, you have to think about antibiotic which cannot cause harm for the neither for the baby nor for the mother. I will give you at least here 5 examples which is safe for pregnant. Number 1, penicillin. Number 2, cephalosporins. Number 3, meropenem. Number 4, macrolide, not all of them, azithromycin and erythromycin, clindamycin, and nitrophenolone. All this is relatively safe compared with others, but there is maybe more. Also, you need to take culture ideally before start antibiotic, so it will help you to decide, are you doing well or there's any problem. We have here example CAP, which is community acquired infection, pneumonia. Sorry, community acquired pneumonia. Patient here we have 45-year female with 2 days history of fever, cough, and chest pain, nasty brown sputum, vaccine not up to date, fever up to 39, heart rate 105, respiratory rate 35, oxygen saturation 91. Clear differential diagnosis, it's either bacterial or viral, and in bacterial you need to cover typical and atypical. What we mean by atypical is a bacteria without cell wall. So if you give antibiotic which work on cell wall like beta-lactam, it will not work. So what you have to give, can somebody give me antibiotic which will work or atypical organism? Can somebody name antibiotic which will work on atypical organism? Azithromycin, yes, 1. Clasid, clarithromycin, yes. Levofloxacin. No, it's ceftriaxone, wrong. Doxycycline, absolutely. So sometimes you need to, for example, to avoid azithromycin or levo because of QT prolongation, doxycycline is a good option. Thank you very much. Moxifloxacin also. You can do a CARBS score to decide the severity of illness. So if you think about the same systematic way, so when you did the CARBS 65, it's a score help you to decide the severity of illness. So if you score the higher score, the higher mortality. This patient score, for example, more than 2, so you need to admit the patient to the normal ward. What's the source of infection? So most likely for community-acquired pneumonia, Streptococcus pneumonia, and a typical organism. Drug resistant. This patient, he don't have history of recent antibiotic, and also you can depend on local antibiogram for your community. Based on this, you can decide which antibiotic. Patient factors, there is no allergy, no normal renal, not pregnant. So you can take also the cultures before starting antibiotic. You can take sometime blood culture, sputum culture, and urine pneumococcal antigen if it's available. So based on this, we decide to give ceftriaxone and azithromycin to cover a typical organism. When we did that initially, and after 2 days, patient improved clinically. After 3 days, the culture became Streptococcus pneumonia sensitive, and we de-escalate. So de-escalation is one of the main principle of stewardship. So go to narrowest spectrum possible, which cover the organism at which go to the site of infection. This is the last 2 slides. Here I will focus on the core element of stewardship, and I will focus mainly on the leadership commitment. Leadership commitment, I believe it's the single most important core element of the 7. If there is a leadership commitment, not necessary from CEO only, but from all departments, from medical, surgical, ICU, nursing, head of pharmacy, if there is commitment, and this commitment transfer from person to person, I believe that this will lead to very successful antimicrobial stewardship program in your organization. Of course, we have to do monitoring, we have to do DDD, DOT, etc. But if there is a leadership in from day one commitment, it will continue till the end. There is different strategy you can perform your stewardship. Restriction and audit and feedback is the main 2. Each one have its pros and cons. With restriction, maybe sometime it will delay the treatment, because restriction, you need to take approval before prescribing. On the other hand, audit and feedback, it needs more human to do the work. So you can review the antibiotic next day and see if there is something done wrong, correct it, educate, and carry on. I believe we have to do mixture between both, maybe restriction during working hours and audit and feedback in the after hours, because communication maybe will delay if the doctor want to take approval at night, and he will delay because of that point. So better to do audit and feedback out of hours. This will lead also another thing like de-escalation. You need to do education, you need to do guideline, you need to apply IV to oral when it's possible. The patient tolerating the IV, and there is alternative medication which give the same effect. It is also one of the principle of antimicrobial stewardship. And I'm done. Thank you very much. I hope it was done on time. I hope my voice was clear to everybody.
Very clear and on time.
Thank you, Dr. Saeed. Thank you. Thank you, Dr. Saeed.
Welcome.
Hello. Now, Dr. Hussein Alawadhi.
موجود.
Welcome, Dr. Hussein Alawadhi. Dr. Hussein Alawadhi, he's graduated from Bahrain Arabian Gulf University, and after that he went to the USA and start internal medicine residency program. He completed American board certificate, and he joined Harper One State University in the pulmonary fellow program, fellowship program. He is interested in the infectious disease. So he completes the fellowship in the infectious disease. He's American board in critical care and infectious disease. He was previously working in Al Mafraq Hospital as chief of the medical ICU, and recently certificated in American Board of Medical Quality. Currently working as a consultant infectious disease and intensive care at Sheikh Khalifa Medical City, Ajman. And I'm here also. He's have a good experience in another Gulf countries. Welcome, Dr. Hussein.
Allah يحفظك. Can you hear me all?
Yes, just I want to thank Dr. Imad. He's he's with us today. He will capture the questions. So please, if you have any questions on my slides or Dr. Hussein, please ask any time, and Dr. Imad will ask us in the end of the session. Thank you.
Assalamu alaikum. Can you hear me? Can I start?
Yes, we can hear you very clear.
Yes, start.
Assalamu alaikum. Thank you very much. I'm very happy to be with you, all of you here. Eid Mubarak. It's too late for the Eid, lakin inshallah, we are being safe and protected, so we are celebrating Eid. Alhamdulillah, alhamdulillah, thumma alhamdulillah. So I will go to the topic directly, because the concept of microbial stewardship has been very clear, mentioned, structured by Dr. Saeed. So thank you very much. And I will take you straight forward to the COVID-19. And I wrote here what we learned so far, which means we are still learning.
الصوت انقطع دكتور.
Okay. There's all these my education objectives, and we'll focus on COVID, and I'll try to show you COVID patient, they have bacterial infection, and are we doing right when we give antibiotic to our COVID patient? So my discussion is purely about COVID. I have one important non-education objective, because we as a physician, when we work and you learn and get the knowledge and the advantage and support from our pharmacists, at the end, the patient is happy. So I'm very happy that I'm working today with the Emirates Society of Pharmacy. So this is wonderful. Inshallah, this work is always needed. We need the pharmacy to support us. And the pharmacist is supporting the physician, because the aim, the goal is to make the patient happy. So this is very good. So thank you very much for organizing this activity. So let's go to the business. Now, it is well known that if you have viral pneumonia, like influenza, you will get secondary bacterial infection. In this review, those who had severe influenza pneumonia, they had Haemophilus bacteria, strep pneumonia, Staph aureus. So if you have influenza pneumonia, you are 30% likely to be co-infected with these three bugs. So this is well known, actually. This is also in the past, again, this is in the past, the H1N1 pandemic. The people reviewed the rule of bacterial pneumonia in this H1N1 pneumonia, and they reported 20 to 20% of having bacterial co-infection. Majority are strep pneumonia, strep pneumonia, strep pneumonia, even if you are inside the ICU or you're outside the ICU. So this is high. 20% is high rate. This is now this is a nice study. They look a different way. They look to the people who had confirmed bacterial pneumonia. So they presented with bacterial pneumonia, and then they looked, do they have secondary viral infection? So all the cases of confirmed bacterial pneumonia, they search for virus. Our topic today is opposite. We have a viral COVID pneumonia, then we search for bacteria. But in this nice article, they said we have a confirmed bacterial pneumonia, but let me see they have a viral infection. And in these series, those who were in the ward were 24% had a viral infection. We don't know who started first. The viral infection caused the pneumonia. And those who had bronchoscopy sample and they looked to the lung deeply, 44% of them, they had viral infection. And those who had both viral and bacteria, we don't know which one started. Was it bacteria and superimposed virus? Was it virus superimposed bacteria? But in this systemic review, if you have both, the odds of dying is 2 times, which is a really reason for you to think of giving bacterial antibiotic. So this is the statistics. It will change. This is the coronavirus. MERS is a coronavirus, mortality 35%. This is the SARS. It is a coronavirus, mortality 15 to 10%. And this is the initial result from China. Again, this is the initial from China, which is the MERS, the COVID, and mortality reported 2%, but different places in the world, in Europe, United States later, was different mortality. So if COVID virus is very contagious, and if we know that any regular viruses, you are high likely to get secondary bacterial infection, then you can say it is logical that our COVID viral pneumonia more likely to get bacterial infection because the COVID virus is more contagious. Now, recently, again, you can see in the media, this is the media. And as I said, do not believe the media. Everybody is talking about COVID. Every single person with knowledge, without knowledge, with PhD, without PhD, talking whatever he says in COVID, and unfortunately people sharing the information in WhatsApp and Facebook. Look to this information. COVID-19 patient needs to be tested for bacteria and fungi, not just the coronavirus. And it says here, many hospitalized victims are developing potentially lethal secondary co-infection. This is all rubbish. This is not true, by the way. I will give you a reference. So I click on this blog, and this is the reference blog, Scientific America. So I click to see who said that they have many bacterial infection. Okay, and this is the reference. So if you click on it, it will take you to a place called CDRAP. So everybody is sharing information from somebody, and they took the title. So here they say 1 in 7 have bacterial infection. Here they say 50% have bacterial infection. Then I try to find them and go to the original article, which I will show you later. This is all not true. Here, old age, sepsis tied to poor COVID-19 outcome and death. And here it says, those who have a sepsis, their chance of dying is 0.0001%. And people say the sepsis means bacteria, and bacteria means give antibiotic, and antibiotic means give meropenem, give lanusirid. That's the way people think. And this is one of the articles quoted, but all the information mentioned here is not true. We'll come to that. Co-infection, potentially lethal and unexplored. Patient take the first sentence, it is lethal, let's start antibiotic. People don't read the end of the sentence. It's unexplored area in COVID. So let's see the evidence. Do patients with a COVID really have serious bacterial infection? When I say that, close your eye and think, in your ICU, in your hospital, how many COVID patients you are giving antibiotic? I'll use you are throwing antibiotic on them. See the data now. So in this study, and this is all from 2020, okay, this everything I show you from 2020, rate of co-infection between SARS-CoV-2 and other respiratory pathogens, Journal of American Medical Association. It was in North California at the beginning of COVID. Every single person coming to the hospital searched for COVID, and they searched for other viruses, and they searched for other bacteria. They found 20% have COVID, and they found other viruses and other bacteria. But those who had a positive COVID, minimum few of them had bacterial co-infection. And those that were tested, none of the 116 tested were positive. So the co-infection with virus was 20%, means you have a COVID patient, COVID virus, you have 20% of them, they have other viruses like respiratory syncytial virus, they have rhinovirus, so you have 2 viruses, but none of them had any bacterial infection. This is another view Okay, this is from 918 cases. This is from publication. Out of 900 confirmed COVID, only 7% of them had bacterial infection. And these 7%, that bacterial infection, they are not all of them superimposed bacterial pneumonia. They were bacteremia due to central line. They had UTI due to Foley catheter. So in this series, they said which patients are at risk of COVID patient bacterial infection if they have central line, if they have diabetes, and if you threw 2 antibiotics to your patient empirically at the beginning, later they get more infection. I call this antimicrobial non-stewardship. So you have a COVID viral pneumonia, you threw at the beginning 2 broad spectrum antibiotic, then later your patient will have either UTI or line infection. And this is bad actually. This is a funny, by the way. This is case report. Somebody published a case report of streptococcus pneumonia with COVID pneumonia. It's which tells you this is rare. This is another study, 813 adult patients, okay, with confirmed COVID pneumonia. Look to here, 95% of them received antibiotic. Now, I don't blame them because this is in China, the first time they've been hit with COVID. They didn't know. Maybe we did the same thing. But when they published the data, 95% of COVID patients, they're being given broad spectrum antibiotic. People think if you are giving antibiotic, you're right. That's not an antibiotic stewardship. And in this study, they found half of the patient developed sepsis. And this is the first article that I referred to. Sepsis does not mean bacterial infection. Sepsis means you have hypotension, you have altered mental status, you have high lactic acid, you have hypotension. Sepsis could be bacterial, could be viral. But people, when they hear the word, oh, that patient is septic. Yes, he is septic, but this was a viral septic. So nothing in this article out of these cases mentioned about bacterial isolation. And here, they wrote there is secondary infection, 50%, but they meant sepsis, not an infection. And on those who had secondary sepsis, look here, they mention here day 17, you can see here in the slide. So at the beginning, they had a viral pneumonia, okay? They have a viral pneumonia. You can see that they develop sepsis here. But in the first 7 days, 10 days, there is no bacterial co-infection. Question to you, all of you, look to your patient today. When you're in your ICU, in your ward, your patient are admitted with a COVID pneumonia on the first week, are you giving your patient antibiotic? These case series, no bacteria was isolated. Only down the road on day 17, they have secondary infection, which could be line related, which could be Foley catheter related, rather than secondary bacterial pneumonia in the lung. We see secondary bacterial pneumonia in the lung in influenza and the previous viral infection. Now, this is also another 99 cases review in this slide. Again, this is all case series. 1% only, okay, had bacterial co-infection. Only 1 case Acetobacter baumannii, 1 case Klebsiella, 1 case Aspergillus. Very few. So, in summary, majority of the initial publication from China, they said, yes, we're throwing antibiotic of majority of them. But when they published the data, they did not find a bacteria. And again, I'm giving excuse because they were hit. Maybe any country is hit by a new infection. They said, I will not take the risk. I will throw the antibiotic. How, I don't know. But now we have a time to learn from them. And this is one of the articles actually that people misinterpreted. So in this case series, there are 40 patients. Again, each hospital center in China, they publish their report and experience. So only 40 patients out of 40 patients, 4 patients had secondary bacterial infection. They did not mention what kind of bacteria. 4 out of 40 is 10%. It looks high, 10%, but this is 40 cases only. This is another also review from 1,099 patients from China. This is published in April 20. And again, in this series, 58% of patients received broad spectrum, so 2/3. None of them, as per the report, that they did not show or they did not show or publish any bacterial co-infection. When I say they did not publish in the article, it doesn't mean they had, but I can say there is no evidence of a true infection. I assume it was there, they will check it. Another review, 138 hospitalized patients. Again, nothing mentioned our bacterial co-infection. They describe everything, the renal function, liver function. So all the previous article I showed you, they went in detail. I'm just showing the part which talks of bacterial co-infection. I did not talk about the other part at all. They described the lung, the ventilator, the kidney, the CPK. I am not mentioning them. I'm just going to the area of the bacterial co-infection. So 138 cases, again, they said 2/3 of them received antibiotic, broad spectrum, okay, but nothing they mention about bacterial co-infection. Even in their secondary mortality review analysis, those who died, what was the risk factor of death of COVID? Age was a risk factor. If the patient had a COPD to start with a risk factor, patient had a heart disease risk factor, diabetes, hypertension. They did not mention that infection is a risk factor for death because there was no infection reported. So all the previous publications showed low to very low rate, sorry for typo error, low to very low rate of bacterial infection, but unfortunately, it showed very high rate of antibiotic administration. Now, this was in December and in January. Now we have time from the Chinese publication to learn about this. We should not do the same thing. So COVID-19 may worsen antibiotic resistant crisis, and that's true because everybody is throwing antibiotic. So this virus is going to destroy our antibiotic. So I like this nice message from the British Society of Antimicrobial Chemotherapy, and this is a message from the CO. They said the link between COVID-19 and drug-resistant infection is more troubling than many realize. Antibiotics were not effective against virus are being used frequently in large scale in people with COVID to prevent or treat suspected or confirmed secondary bacterial infection. So in the current situation, they say this is not right. This trials and studies should be conducted to choose the proper antibiotic therapy and to limit the spread of antimicrobial resistance. And what was Dr. Saeed was telling is antimicrobial stewardship. So antimicrobial resistance will likely increase. So for the last 3 months, 4 months, I'm sure everybody is throwing antibiotics. We may see a bad result in the coming 2-3 months. That's bad. I hope it will not happen. So secondary infection, antibiotic chemotherapy, and antiresistant in the context of COVID-19, you can go for this reference. And so many people are warning us that what's killing this patient is the viral pneumonitis, okay? It's not the bacterial pneumonitis. It's not the bacterial superimposed. And people say, my patient is febrile, my patient has high CRP, high procalcitonin. And you may think of COVID storm. If you did not hear about COVID storm, please read about it. I think the majority of the patient deterioration is due to severe inflammation. It's called the COVID-19 cytokine storm. And you can read this nice review, the pathogenesis and treatment of cytokine storm in COVID-19. This is not our today's discussion, but something interested to me because we talk about all the biomarkers here. It's all mentioned here. At the end of my presentation, I will stop and talk about one single biomarker. So what we should do to wisely use the antibiotic, the message, go to our principles, as Dr. Saeed mentioned, antibiotic stewardship. Go to your guideline, the right drug, the right dose, the right time. You know what bacteria you're covering, they're gram-positive, gram-negative. So we have few advices. The British Center of Evidence-Based Medicine, in April 8, 2020, They published their differentiation viral from bacterial pneumonia, and they gave us some nice, and it's available on the website. By the way, anybody wants my slide and presentation, you can take it completely, entirely, the whole PowerPoint. So they says you think of viral pneumonia if you have the following thing, which is mainly myalgia, back pain, low smell, and dry cough. Think of bacterial pneumonia if the patient has pruritic pain or the sputum is purulent. So patients admitted on day 2, day 3, day 5, day 6, the sputum is becoming green, becoming more. Then you can think of bacterial co-infections. Or there's a unilateral patches in the X-ray. If you have diffuse bilateral infiltrate, is most likely viral. If you have patches and consolidation, it suggests more of viral, bacterial infection. And they advise here, do not offer an antibiotic for treatment or prevention of pneumonia if COVID is likely the cause and symptoms are mild. Give oral antibiotics. So if you have a patient with a COVID pneumonia and the patient are immunocompromised here, they have heart disease, they have lung disease, then give them oral antibiotic. What they recommended there, doxycycline, amoxicillin, not tazocine, not ertapenem, not meropenem, not lidocaine at the beginning. You don't need to give this at the beginning. Simple. We give in our centers ceftriaxone if there's an element of bacterial infection, because on day 1 they will not get your XDL, MDL, Klebsiella, ESBL. So there's no point, and it's actually wrong. You cover them with ertapenem or meropenem or the new generation, the bulbuli, beta-lactam inhibitor. So use a simple coverage if you have to do. I will skip this slide because this was discussion about clarithromycin as an antiviral effect, and the conclusion was says that we do not have an evidence to use clarithromycin. Now, few final slides. Bacterial and fungal co-infection in individual with coronavirus, a rapid review to support COVID-19 antimicrobial prescribing. This is a nice review. They reviewed all the coronavirus. For you to remember, the coronavirus are the SARS, the MERS, and the 2019 COVID. These are all coronaviruses. So they reviewed everything in these previously because at the end they are corona, but it doesn't mean that the same bacteria or virus we had in SARS or MERS, it should be the same as, but this is what a recent publication, May 2nd, so this is month of May. So what they did actually, they reviewed English literature, Chinese literature, anything published in Chinese language, and this was the initial time that Italy was hit, so they reviewed. For those who had COVID, their review only 8%. 8% has a confirmed bacterial co-infection. Go back to your patients. Go back to your ICU today. Go back to your medical ward today. Today after lecture, go to your ward. Just pick up 10 patients or 20 patients with a COVID. See what percentage of them they are on antibiotic. The evidence says only 8% of COVID. For the SARS and the MERS is higher, but the COVID is less. So most of the studies fail to differentiate the setting where sampling was performed. Means those who proved infection in the SARS and the MERS, they did not show how they proved the bacterial infection. Yes, they published, they said we have this percentage of bacterial infection, but they did not prove, because you may isolate a sputum from a trach patient and you say this is pneumonia, while this be colonization. It doesn't mean if you isolate anything from sputum or from the nose or the mouth, it means the patient is having infection. And again, they reviewed all the publications from China, USA, from Hong Kong, Taiwan, Singapore, Saudi Arabia, Canada, and South Korea. So they come to this two important conclusions. Please consult infection specialist. It could be an ID consultant if you have, or a clinical pharmacist, either of two, who are normally responsible for coordinating stewardship program. must continue to provide support to clinical teams managing COVID-19 patients to ensure that regular review and cessation of antimicrobial therapy, supporting appropriate microbial sampling. So this is my advice to you. Go back to your hospital, says we need to involve our clinical pharmacist. Involve your pharmacist. Pull him up to the pharmacy if you have enough. Let them learn the clinical concept, and gradually it will be very beneficial to you, to your patients. And do sampling. If you decided to throw antibiotic on your patient, please request for a sample. You will say patient did not have a sputum at all. That tells you it is not bacterial infection, it is viral. But if the patient has a sample sputum, then you can de-escalate the treatment. This is also another recommendation. This is from the published May 11, Recognition and Management of Respiratory Co-infection of Secondary Bacterial Pneumonia in Patients with COVID. Again, they review literature and they try to give you an advice how you can manage them. So they're very nice slide, and this is from that review. It says, viral co-infection incidence varies based on case series. 0%, as I showed to you. So many cases don't have any bacterial co-infection, some up to 15%. It's not a lot. It's not a lot. Combined bacterial and viral infection is rare in COVID-19 patients. Secondary bacterial infection is not uncommon. Not uncommon means it could be common and leads to significant morbidity and mortality in elderly. So maybe in elderly people with these few references, they may, because they have higher mortality, they says the mortality is higher, probably because they had a bacterial infection. So what to do? Procrastinating. Procrastinating is an excellent marker if you use it properly and you act on it properly. It's a very bad marker if you use it badly and you ignore the result. What I've seen many people order procrastinating and the procrastination is normal. They say, let's continue 7 days, and it's not right. Okay, so procrastinating said it can guide you in your patient, but remember what they say. Many COVID patients, especially COVID storm patients, which they have high ferritin, high D-dimer, high LDH, high microglobulin, they also have a high procrastinating without proof evidence of bacterial infection. So if your level is normal and your patient is symptom free, do not give antibiotic to prevent the COVID deteriorate. Don't say he's a mild COVID, I will give antibiotic to prevent him deterioration. No, don't do that at all. Now, elevated levels are correlated to 5-fold higher risk of severe SARS-CoV infection. Okay, so yes, those who have COVID, severe COVID infection, we noticed that their carcinogen is very high, but we could not prove it's due to bacterial infection. Don't know. We are learning about procrastinating in COVID. It was studied before. Elevated are not specific to bacterial infection. Okay, and so this is the message I have here. And a normal level makes bacterial infection less likely and can guide antibiotic discontinuation. So you order procrastinating, it's normal day 1. You say maybe next day the patient is sick. I said that's fine. Continue until the second day. Repeat procrastinating second day, and it's still normal. You say, oh, the patient is still normal. The patient looks fine because of antibiotic. That's not true. Then majority of people, let's finish the course of 7 days. As I said, don't procrastinate. If you use it properly, I love it. I like it. If you use it improperly, please don't order it. Don't waste the money of your lab. It's an expensive test. You waste the hospital budget and money. Order a test. You don't act on it. It is causing you to lose money. Don't order it. So it's the misuse of that procrastinating. So what they said also here, in the absence of supporting evidence of bacterial pneumonia, antibiotics should not be initiated despite progression of respiratory distress. You say, oh, the patient is more tachypnic, more dyspneic. He is not more dyspneic because of bacterial co-infection. It's because of his disease process. Unless you prove bacterial co-infection with a new infiltrate unilateral, with a thick yellow-green sputum, okay, or with a... I think this is my last slide because I was asked to talk for 30 minutes. Now it's 28 minutes because I'm looking to the time here. So thank you very much. Because this meeting was arranged by Society of the Pharmacy. Inshallah, there is a World Pharmacy Day, 25 September. Bi'idhnillah, inshallah, that day, let's celebrate. Will not be a social distancing. We'll sit next to each other in nice place, nice hotel, and do the conference again. Thank you very much.
Thank you, Dr. Hussein.
Thank you.
الو
ايوه تفضل دكتور عماد. دكتور عماد الاسئله عندك تفضل.
Dr. Hussein, there are several questions I think you have covered, but if you want to emphasize the answer, it's up to you. The first question is about diagnosis of secondary infection relying on X-ray or symptoms. Can we start antibiotic based on X-ray?
Who asked the question? Who asked the question?
Dr. Khulud.
Okay.
Okay, so the question is easy, the answer is difficult. Now, let me make it more complex on you. It's a habit of the doctors and people. If the patient is sick, the treatment is an antibiotic and broad spectrum. So whatever we try to convince people, study with the data, he's sick because it is viral infection. We cannot convince people. They said, let's continue 7 days. So going to the question, if you want to do a serial procrastinine, for example, and it stays in the low range, then stop the antibiotic. If it stays in the higher range, it could be the COVID storm, it could be viral pneumonia, or it could be bacterial. Then if you decide to give antibiotic, then give for 7 days, and if you culture and the culture did not grow anything, then please stop the antibiotic.
I think also you covered the second question about procalcitonin value in bacterial secondary infection.
Okay. So the procalcitonin is as I said, it's a biomarker. Many people don't like it. Many people like it. Many people don't know what to do with it. They just waste the hospital money by ordering procalcitonin. My message: one, previously, procalcitonin has been studied in bacterial infection. It's very good. Has it been studied in coronavirus? We don't know. We don't know. We don't know. So if you want to use it, but guide your treatment. Today, I had a patient whose procalcitonin was normal for 0.6, 0.5, 0.3, 0.2, 0.2. Suddenly today is above 100. And there is no leukocytosis and there is no fever. So the team asked me to consult what to do. I said, if the patient is getting worse or not. They said it's not getting worse. I said, then order sputum culture, order blood culture, don't give antibiotic, just observe it.
Also, Dr. Marwa asks about PCR in detection of bacteria during pandemic.
Yes. Now, we know that coronavirus, all the detection is PCR. Okay, so this PCR is specific for the novel coronavirus. Many hospitals, like our hospital, we have a PCR. It's a multiplex PCR. It is a respiratory panel. So there was at the beginning of coronavirus that if you have that available and you have a patient has a COVID symptoms, but the test is negative for COVID, then maybe other virus. So initial recommendation says, please test for other viruses. Now, all other viruses except influenza, we don't have a specific anti-influenza. But this at the beginning of this pandemic. Now, nobody is doing because majority of cases are classical, straightforward COVID pneumonia. But if you have the facility, you have the budget, it's good for It's not good during pandemic area. It's good later when the pandemic settles down, because you don't know what to do with result. The result will take time, 5 days. So your management will not be affected by the result.
Can I add one comment, please? For those people who's asking certificate, I put a link for a form. You can fill that form, and if you need the slide also, just mention you need the slides. I will send you the both my slide and Dr. Hussein's slide in the form, and also you can evaluate. And if you have any comment or on how we can improve, please mention that. Thank you.
I have a question for Dr. Saeed.
Yes.
What is the impact of antimicrobial stewardship on your antibiogram in your hospital over the past 2 or 3 years?
Let me first tell you, Alhamdulillah, we notice the level of resistance is reduced compared. We start our antibiogram in 2016, and we are doing yearly antibiogram, and we are seeing the first of all that we can say not disappearing. The number of resistant organisms is reduced dramatically compared before 2016. Everybody talking about this, and when we do our antibiogram, we notice that even the Pseudomonas, for example, sensitivity is increased. It's not that much increased, but there is an increase. We can notice that for the sensitivity. But the problem really now, we are looking for 2020 data. You know, Dr. Jens, he's collecting data from all UAE hospitals. So I expect the population of the organism will change dramatically this year, because maybe we can see, I don't know if we can see more community acquired bacteria. Maybe the resistant level will increase if people continue misusing the antibiotic. We are waiting for the next year really to see how is this year compared with last year. Thank you.
Also, there is a question for Dr. Hussein about the concept of using azithromycin as a regime for treatment of COVID-19 along with other trial medications. Dr. Shad is asking if you can please elaborate on this.
Yes, because thank you very much. Because we are in United Arab Emirates, I'm sure all of you has been receiving in the WhatsApp, Facebook, the national guideline. So my first answer: follow your national guideline. That's what you're getting officially from expert people in the field, more knowledgeable than me, more expert than me. So whatever it says there, follow that. That's number one. Number two, I showed you specifically from the British Society. In my slide, they specifically commented on that antibiotic. I skipped it quickly because of time, but they say there's no evidence using it alone. Now, azithromycin by itself is an excellent antibiotic, but if you're going to give it time, like any quinolones, there's a risk of prolonged QT interval. When you give it with chloroquine, which has also more risk of QT interval, so you're giving two drugs which both together can prolong QT interval. So I'm here, all of you heard that Lancet article was published last week. I think they reviewed 90 or 100,000 cases, and the recommendation was not in favor of the chloroquine. Then after that, we heard some political answer. These companies, they want to talk bad things about cheap drugs. They want to sell expensive USA. Discussion, I don't know. We stopped using Zithromax or Azithromycin in our patients. I don't think so. They are useful. My personal review of the data.
Thank you, Dr. Hussein. There is a comment by Dr. Khulud about the problem of sampling with antibiotics. She's saying maybe sampling happened after starting of antibiotic. That's why results are coming negative.
Okay, very nice question. Now, when patient with viral pneumonia COVID pneumonia, the beginning of this infection, that means this discussion was in February, okay, February. Everybody was talking about aerosol generating procedure. Do not let them cough. If they cough, they produce more aerolized virus and affect the nurse, the doctors. You remember that very clearly. So because for the patient to give you a sample, he has to cough and he has to give sample and deep cough, so the sputum will come out of it. So majority of people avoided requesting sample at the initial admission. Now this all changed because we have, if you take your protection, the N95 mask, and you take the full PPE, then patient should be able to cough without you being infected if you take care of yourself. That's the beginning before you start. Now let's say you started the antibiotic. I will still recommend you to do sputum sampling. Your yield is around 30%, but still, if you get a sample of your patient and your yield is 30%, is better than nothing. Means 30% you will know the bacteria and the sputum. Then you can decide, is your antibiotic right or wrong? The other 70%, it will not grow because you started the antibiotic. In that case, I will tell you that fine, stop at 5 or 7 days maximum. The patient is in the ward, 5 days. If the patient in ICU, 7 days. Unless he's in septic shock, multi-organ failure, that's another discussion.
Thank you, Doctor. One question for Dr. Saeed. How long did it take you after AMS implementation to improve the behavior of bacteria and improve sensitivity?
Actually, we saw the result within the next year, 2017. There was little change, but in 2018 and 2019, we can notice the improvement is higher. So it will take at least 3 years to see there is good results. It's long-term work, and it's also it's a behavioral change, and also teamwork. It's not easy, but it's done by teamwork, and everybody should understand the importance of the stewardships to reach to this successful program.
On the other hand, how long does it take bacteria to develop resistance?
Dr. Hussein.
Bacteria are very smart. Bacteria, if you give today, I have seen many cases, you give antibiotic today, within 10 to 14 days, 30 days, it's resistant. And that resistance is not to him. He will spread to other people surrounding him. So you make one patient carry a bad bacteria, it will not affect that patient, it will affect the people surrounding him. But now we are seeing less spread of infection between patients. You know why? Because everybody's afraid of coronavirus. So everybody's washing the hand between patient to patient. That reason we are not seeing any nosocomial spread. But once the corona subside, I think people will go back to the old bad fashion while not doing hand hygiene, and the bacteria will spread again. Now I have a question to the audience, or to any of you, or you. If you suspect a patient or your family, you suspect that he may have a cancer, he may have a mild cancer, and you went to an oncologist and you said, please give him some chemotherapy. An oncologist says, no need for chemotherapy. Would you give him chemotherapy or not?
No.
I know you're suspecting cancer. Why will not give him chemotherapy?
I am not the expert.
Very good. So in your hospital, if you don't have ID doctor, call your microbiology or your clinical pharmacy. These are 3 experts in antibiotic. They will help you. They will guide you in your hospital. When they say don't use antibiotic, it doesn't mean they will not follow up the patient. This is don't use. For example, if your oncologist, oncologist says no need for chemotherapy. But oncologist will say, we'll do another CT scan, PET scan, biopsy in 2 weeks, 4 weeks. He will follow up the patient. So we as an ID doctor, when we say don't use antibiotic, it doesn't mean we are 100% right. We will follow up the patient. Okay, let's by day 2, day 3, day 4, you for the patient you said, Dr. Hussein, the sputum growth something. I said, oh, then let's start the antibiotic. So message to you, you need to involve your team. You need to create a team. You can be a regular GP doctor or regular specialist and get expertise in antimicrobial stewardship and training. There's a lot of online course you can go for it and you learn that.
Thank you, Dr. Hussein. I think no more questions.
I have a question to Dr. Hussein. Can we utilize CARE 65 in COVID patient?
We don't know. Studied.
Bacteria and microbes around us, they are telling us we are not alone on this planet. Thank you, Dr. Hussein. Thank you, Dr. Saeed. I think we have reached the end of our webinar today. And I hope to repeat this again in the near future.